We are live now.
All right.
We are live.
Hello, everyone. I am Dr. Jasmine Marwaha, and I welcome you all to Global Interdisciplinary Summit, organized by Global Outreach Medical and Health Association and Global Summit. And today, I'm back with another renowned speaker, taking a day further. And to begin with this session, I, on behalf of Global Interdisciplinary Summit, heartily welcome Dr. Ashwini Bhalerao. Talking about her, Dr. Ashwini was named Oral Surgeon of the Year in 2013 by the Famdent Excellence in Dentistry Awards. She was instrumental in initiating the use of piezo-surgical unit in implant-related surgeries, such as sinus lift, ridge split, and bone augmentation. Dr. Ashwini started the use of obturators during and after oral cancer surgery for faster rehabilitation. She is well versed in surgical techniques and is a frequent speaker and author. She received her bachelor in dental surgery from Naya Dental College, Mumbai, where she also earned her master's. She also received her postgraduate diploma in medico-legal systems from the Symbiosis Institute of Healthcare, Pune. Today, she'll be talking about a very interesting topic, wisdom about wisdom teeth. And I'm sure this seminar will be profitable and the next few hours will be fruitful for every one of us. So before moving ahead, I would like you guys to register yourself for CE and speaker schedule and other details. Please visit www.gomha.org. Thank you. Over to you, ma'am. Ma'am, you need to unmute.
Let me just unmute it. How do I? Sure. Yeah. How do I? Okay. So I'll start talking. So thank you, Jasmine, and thank you, Goma, for this opportunity. Thank you, Dr. Kianon. It's always a pleasure working with you. And Rakesh, thank you. In spite of yesterday's technical glitch, you really rescheduled everything and managed to get this Facebook live session. So thank you, Rakesh. Thank you, Jasmine. Now I think I will start my presentation. India right now, Jasmine, Rakesh, Dr. Kiano, everybody, the whole world in fact is going through some serious crisis, something which we have never dreamt before. In spite of this, amongst all the countries, I feel we Indians are doing a great job. So I would like to show just a glimpse of our glorious country and pay a tribute to us, the citizens. So yes, this time too, we shall emerge victorious. The lockdown will end soon, and we will be back to doing dentistry at what we are good at. So my message right from the beginning is stay safe, stay strong, stay at home, and watch webinars. So I have been in practice for the past 26 years, practicing exclusive oral and maxillofacial surgery. Practicing oral surgery is my passion. Since the last couple of years, I have found a new passion, that is teaching and sharing what I have learned from my successes and failures over the years. These are a few of my cases done over the years. And let me tell you, the appreciation what you get from a surgery patient after you have restored his face to normal is nothing compared to any other work that you may do. Oral surgery is a glorious specialty. My motto has always been live to learn and learn to teach. Every year, you must have a goal of learning some small point, be it in your personal or professional life. And whatever you learn, you must learn to equally share it with others, teach your juniors, so knowledge spreads and what goes around comes around back to you. Wisdom about wisdom teeth is one of my most favorite topics to teach. The confidence what you get from your surgical skills is something that just cannot be explained. Surgical skills are the foundation of every branch. You hear of big time general practitioners, and what is that one thing that sets them apart? Their patients go and say, oh, he's got a gentle hand. Do they talk about his prescription skills? No. Do they talk about his personality? No. They talk about his hand. So, your surgical skills, be it taking a suture, giving LA, or anything as minute as taking out a mucocil, has to be top class. So strengthen your foundation, and once you strengthen your surgical foundation, then learning other skills, learning any other procedure, a conservative procedure, endo procedure, implant procedure, becomes much easier, because you know, worst come to worst, what will happen? I will have to go invasive, and I know how to go invasive. So this is one of my students, Jitendra, who was scared of doing even normal extractions. But after he learned how to remove wisdom teeth from me, he does everything, all the most complex implant surgeries. And he says, ma'am, it's only because of the third molar disinfection surgeries that I do, I have got confident that I can handle the worst situation I may find myself in. So let's see what are the 5 commandments of this procedure. Establish correct diagnosis. Does this wisdom tooth requires removal? Plan the procedure then to the last detail. Sterilization and instruments. It's extremely important in surgery that you operate in a well sterilized, disinfected operating room, and you're using the correct instruments. Follow-up care of the patient is also very, very important, right till suture removal and post-op. After that too, till the patient is as good as he was before he got infected. So what's our treatment plan? Our objectives should be short operating time, minimal trauma to the soft tissues, adjacent teeth and bone. Zero trauma would be the correct word. Painless procedure, and of course, no complications. First thing first is that take good x-rays. Check these x-rays for the angulations which will determine the path of removal. Once you look at the x-rays, you must also look at presence of pathology and restorations. Proximity to the vital structures, that is the IA and nerve, that is the maxillary sinus, and the root morphology. Is it multi-rooted? Is it conical? Is it dilacerated? You must see this very carefully in the X-ray itself. Then the depth of the tooth in the bone. Is it below bone level? Where is the CEJ of the 8? Is it above the alveolar crest, below the alveolar crest, supra-erupted, around the nerve, or is it close to the inferior border of the mandible? Is it close to the sinus? This is what you will notice. One clue. Now, can you see the photograph on top? It's not of a third molar, the X-ray, but can you see the apex is rounded? So just looking at that apex, you must be able to diagnose that rounded apex means it is a dilacerated root into the buccal or the lingual cortex, and this requires a surgical removal. If you try just elevation, you're going to be ending up with a broken tooth like that. Then you will see the lower X-ray. Can you take that upper 8 out? Not without surgery. Why? Look at the roots. It's obviously multi-rooted. Look at the tuberosity. The radio opacity shows that it's got a wide, large tuberosity, and the radio opacity coming just around the distal cusp means it is covered by bone superiorly. You need to remove all this bone to be able to shift the tooth out of its socket. So this is how you will read the X-rays. OPGs is a must. OPG will help you diagnose the proximity of the roots to the nerve, the presence of any pathology. CBCT should be recommended once you have realized that there is a pathology on the OPG or the proximity of the nerve of the sinus is there. CBCT helps you understand it in a three-dimensional area. It will tell you the nerve's position in a buccolingual area. It will show you whether the roots are near the buccal cortex or the lingual cortex, how close the nerve is to the apex of the tooth. It will help you plan your procedure. And most importantly, what it does is, it makes it easy for you to explain to the patient. Once you show the CBCT in the three-dimensional form with the colored nerve and all, the patient understands that the abnormality lies with him and he should be prepared for post-op complications like numbness, etc., which may happen, or a OAF, which may happen. Now that will be not because of the surgeon's fault, but because his tooth and his bone were abnormally related to each other. So a CBCT is a welcome boon for us to plan our procedure and, more importantly, to explain to the patient how abnormal his tooth situation is. So this is how wisdom teeth used to be removed long back. Not anymore. We go in a more systematic way. What are the golden rules? Just practice, practice, and more practice. And go slowly. Don't skip steps. There is no race that, oh, today I removed it in 20 minutes, tomorrow 15 minutes. Please don't skip steps. This is the standard protocol. We'll take each point one by one. Medical evaluation, this is not just for a third molar surgery, it's common for all oral surgery cases. Check diabetes, and in diabetes, don't check HbA1c, because HbA1c gives you a reading of an average of 3 months. What do you want? You want the reading to be normal on the day of the procedure. So for that, you have to check blood sugar postprandial and fasting. Without consulting the physician, you can take these counts as pretty acceptable. Postprandial up to 180, 190, fasting up to 130, 140. Anything higher than that, take a physician's consent. Now, many patients and their physicians say that, oh, the patient is insulin resistant, his sugar is always 200 and up, it's never going to come down. So go ahead with that surgery, but what you do is prescribe antibiotics 2 to 3 days pre-operatively, and post-operatively you will insist on good oral hygiene as well as antibiotics for at least 10 days. Cardiac ailment, check history of invasive procedure. Invasive procedure means angioplasty, bypass, stent, anything like this. What this will tell you is whether you need to stop the echosprin or not. Please take the physician's consent if it is an invasive procedure. Any infectious disease in the past 1 year, such as hepatitis, herpes, now we should add COVID also. This means that we are in the danger of getting infected more than the patient. The patient is a carrier. He is immune, but he can pass on that disease to us. So what we need to be careful is about making sure we are covered properly and our clinic is fumigated or disinfected very well post-surgery. These cases I usually keep as the last case of the day. Now, steroid therapy. There's something different about steroid therapy. When a patient is on a long-term steroid therapy, currently undergoing steroid therapy, if the patient has taken steroid therapy 2 months back, 3 months back, 6 months back, nothing abnormal to be done over there, go ahead with the procedure. But if the patient is currently on steroid therapy, then you have to double the dose of steroid 2 days before the procedure, on the day of the procedure, and 2 days after the procedure, then taper it down to the normal dose. This is the only way the body will accept the extra surgical trauma, which is the surgical procedure which you're inflicting on the patient, and the wound won't fall apart but will heal well. History of any drug allergy, obviously you will avoid that drug. Now again, X-ray, OPG is a must. If you cannot take a OPG, take a IOPA, but the IOPA must show the entire tooth and the bone distal to it extremely clearly. CT scan, CBCT is secondary to finding a pathology on the OPG. All these cases, they came to me with pericoronal infection. After I took a OPG, I realized that they were so abnormal. So had I just depended on a IOPA, I would have thought that it's a routine, lower it and gone ahead with it facing complications. So this is the reason why a OPG is a must. Now let's understand level of difficulty. I'm not going to go into the theoretical part like the Winters classification, the depth in the bone, is it class 1, is it level 1, and all that. How does that help us? Nothing. That is theory which you learnt in college. What I'm going to be passing on to you in this lecture today is the clinical tips and tricks. Simple, practical way of planning the surgery and doing it smoothly. So when the tooth is mesioangular, understand it is pretty easy. Yes, everyone thinks a mesioangular is difficult. No, it is pretty easy because it is predictable. Vertical, everyone thinks that, oh, it's vertical, I will be able to take it non-surgically. It's far from the case. Verticals are always deceptive and difficult. Distoangular, we know that there is a lot of bone distally. It's not going to move. So we know that it's going to be surgical and time consuming, and we plan accordingly. Same is the case with horizontal. Never ever judge a tooth by the crown, but by the direction in which its roots are facing. Now, when do you decide it is surgical or non-surgical? The dilemma will come only in the case of vertical position, right? Because if it's mesioangular, you have to do surgically. If it's horizontal or distoangular, it is surgical. In fact, with the horizontal, it's 99% sectioning of the tooth that is required. So where the vertical tooth is concerned, X-ray reading is extremely critical. It's important to check the level of bone distal to the CEJ. If you can see this, this is what is important. The level of the bone distal to the CEJ, it is important to check that. If the level of the bone is above the CEJ of the impacted molar of the 8, then it's absolute surgery. You have to remove the distal bone to even shake the tooth. If distal bone is at the level of CEJ of the 7, then whether it is surgical depends on absence of 7. That means you don't have a fulcrum to elevate the 8. The crown is carious. You don't have a catch. Divergent roots. It's going to be really stuck very deeply, very soundly into the bone. So that time you have to do it surgically. When can you attempt it non-surgical? The tooth is small crowns, conical root, 8 is present. Then yes, you can attempt with just elevation, the tooth may pop out. Sometimes 8s are supraeruptive, vertical, especially if the patient does not have an upper 8. In that case, it can be attempted non-surgically, yet check the extent of the crown intact, check the amount of roots, multi-rooted, single-rooted, check that if the factors are in your favor, then try elevation. Preoperative medication do you always give? In case of cellulitis, infection, purulent discharge, or say a patient needing prophylactic antibiotics such as diabetes or infective endocarditis, then yes, you prescribe antibiotics. But if it's an elective procedure, my style is I don't prescribe prophylactically, say in ortho case or in elective surgery. I prefer to give a loading dose of antibiotic 1 hour before the surgery starts. It works much better and the patients are also happier with less antibiotics going into their body. NSAIDs should you prescribe preoperatively if the patient has pain? Yes. But my experience is that if the patient has no pain, giving NSAIDs unnecessarily preoperatively does not play any role in the post-op pain or discomfort which the patient may go through. That is completely decided by how smooth your surgery is going to be. Now, stopping aspirin or anti-clotting drugs 48 hours prior to surgery should be a decision taken by you and the physician in consultation with each other. Stop ecosprin or clopidogrel if the patient is just taking as a maintenance therapy or because he's stressed out. But if he's taking because of a invasive cardiac pathology, then always take the physician's consent and work accordingly. Now, what is the surgical plan? Understand one thing, that the tooth always comes out in the direction of its long axis. What does it mean? This is the picture. I hope it is clear to you. Draw an arrow straight from the center of the crown coming out through the center of the roots, right? So this is the long axis. The tooth will be elevated only in the direction in which the roots curved. It will come out in the form of an arc and follow the reverse order of the procedure. Don't design the flap first. Now we have a distoangular tooth. This tooth is going to come out only in a backward motion. So looking at that angulation, we have to decide which are the obstacles. First, find out the long axis, find out the path of withdrawal in which the tooth is going to travel. Check what are the obstacles, intrinsic and extrinsic. Intrinsic are bulky crown, multi-roots, maybe the crown of the 7 impinging on the 8, a filling or a crown of the adjacent tooth. Extrinsic would be the bone. Methods of overcoming. That means what are we going to do first? Are we going to section the tooth first? Are we going to do the gutter first? Then after we do that, where are we going to place the elevator? So point of elevation. Then once we have decided that this is where I need space to place my elevator, you will decide the extent of bone removal. Lastly will be the design of your flap. The flap will be 1 centimeter mesially ahead of your bone cut. distally ahead of your bone cut. So it should be a large enough flap planned right at the end after you have decided the extent of the bone removal, resting on healthy bone. Simplify this problem. Don't think that it's a dental or a huge medical problem. You get scared then. Just simplify. Think of it as an engineering or a traffic jam problem, and one by one plan the route in which your tooth is going to come out. It will be much easier in your head. What are the contents of the surgical tray? All these that are shown, they should always be arranged in the order of their use. So your cartridges should be first, followed by your BP handle, periosteal elevator. Which elevator do I use? Freddy P14. This is not a sponsored talk, but I would rather give you the clinical tips straight off so that you're not confused which instruments to use. For a third molar surgery, wherever I go, whichever tooth, whatever be the shape, P14 elevator is the best elevator to elevate this flap. And the most important thing is here is the L-shaped retractor. It's called the Langenbach retractor. It is more effective than even a Minnesota retractor. So always keep this retractor with you for a third molar surgery. Then it's the regular extraction, forceps, elevator, and everything. One thing is different on this tray. Can you see the air rotor handpiece? The angulation, it is a 45 degrees air rotor handpiece. The head is much smaller than your regular handpiece. And what is it called? It's called a disimpactor handpiece. Any handpiece maker makes that. It is specially for third molar extractions. The approach is much easier to section the tooth. Again, the question happens that are you supposed to use air rotor for third molars? Because the fear of causing emphysema is there. Use the air rotor only to section the tooth, not to remove bone. As long as you use the air rotor with a strong suction to only section the tooth, there is no fear of emphysema. And to section the tooth using this 45 degrees disimpactor handpiece is very, very good. It makes your job easier. Do you use it with a regular cavity cutting burr? Not really. You use it with a long shank surgical burr, which is marketed by Comet or Trihawk, the one on the lower handpiece. You can see the difference in the shanks. It's the same burr which is used for socket shield technique. If you use the cavity cutting or the prosthetic cutting burr, diamond cutting burr, with the small shank, what's going to happen is the head of the handpiece is going to rest on the 7 and your sectioning is going to be incomplete. That's when the crown is going to break out in chips. You need to section it through and through at the cancellous bone level below the CEJ. And to reach that level, it is only the long shank surgical burr which will take you. So the burrs which are used for a third molar disimpaction surgery, for bone guttering, it is SS White 703, and for sectioning of the tooth, Comet or a Trihawk long shank surgical burrs. There are just 5 basic steps: LA, flap design, drilling, delivery of the tooth, and suturing. Now, local anesthesia is what you use, cartridges or vials. I prefer cartridges. Cartridges, you can use lignocaine to give the normal block. Use articaine 4% to do buccal infiltration and to give intraligamentary. This gives you profound anesthesia where the patient does not even feel the pressure of elevation. So lignocaine, xylocaine, 1:80,000 or 100,000 for normal block, followed by intraligamentary and buccal infiltration by articaine 4%. If the patient has a cardiac problem or high BP, use mepivacaine, which comes in the Septodont cartridge form without adrenaline, or use 1:100,000 lignocaine. 1:80,000 has greater concentration of adrenaline. So use it in normal patients, avoid it in BP patients. Abroad, everybody does this procedure in conscious sedation. But in India and South Asian countries, we do it under local anesthesia yet. Unless we are doing bilateral impactions or the patient is extremely anxious or unable to cooperate with us, then we can give conscious sedation in our clinics. What are the drugs? Propofol, midazolam, fortwin, or ketamine. These are fast-acting, short duration. If you're doing all four, then do it in the OT. Insist on nasal intubation. That's when the endotracheal tube is passed through the nose, and insist that the throat be packed with a roller gauze or a throat pack so that the patient accidentally does not swallow the irrigating solution or the blood. Now, how should the flap design be? There can be three types of different designs, A, B, or C, as you can see. In A, it is along the gingival crevice, no vertical mesial incision. In B, it is along the gingival crevice, circular clavicular gingiva, but till the 6, right? And in C, it is till the mesiobuccal cusp of the 7, the vertical incision going 1.5 millimeters into beyond the mucogingival junction. I prefer the C because what happens with the A and B is that when you go to retract, invariably you end up tearing the flap at the papilla and then you have scar tissue formation. So give a wide incision, the going inferiorly, anteriorly from the mesiobuccal cusp of the 7, 1.5 centimeters below, along the gingival margin, backwards to the center crest of the ridge, straight across the midline center crest, along the anterior border of the ramus, about 2 centimeters higher, right? And then using a P14 periosteal elevator, take a clean, full thickness mucoperiosteal flap. People are under the misconception that take a small incision and the patient has less swelling later on, which is far from the truth. You take a small incision, you end up pulling the flap with all your might. And that's when the patient comes the next day with like a Hanuman or something, or as though he's got mumps. So gentle retraction of the flap is extremely important to make sure there is no post-operative trismus or post-operative swelling. So for that, take a wide incision, which will give you a better vision. That translates obviously into a easier surgery. And most importantly, keep in mind that you design the flap in such a way that the base of the flap is wide. If you can see from the diagram C, the coronal portion of the flap is narrow, while the apical portion, the portion which is going into beyond the attached gingiva, along the anterior border of the ramus and into the sulcus, is broader. So the base of the flap should be wide, as that gives the blood supply to the flap, which enhances the healing. Bone removal, once you have taken the flap and retracted it with the L-shaped retractor, start your guttering. Guttering should be done with a straight handpiece, straight micromotor handpiece using a 703 SSY carbide burr. It can be an air motor, it can be a micromotor, it can be a physio dispenser. I use a physio dispenser at the highest speed and a brushless micromotor again at the highest speed, which is 50,000 RPM. For sectioning the tooth, I use a disimpactor handpiece with a Comet long shank burr on my chairside air rotor. What is most important of the buccal cut? The buccal gutter, the distal gutter, and the mesial interdental gutter. It should be below the CEJ. it should be absolutely below the CEJ or the furcation. That means that your depth of the trough is in cancellous bone. If you keep it superiorly or superficially, just halfway along the crown length, the depth, you would have only removed the cortical bone. If you remove only the cortical bone, then elevation becomes difficult. The tooth just doesn't budge. So it's very, very important that your depth of the bone gutter all around the tooth, interdentally, mesially, buccally, and distally, should be below the CEJ, almost at the level of furcation. 2 millimeters to 3 millimeters below the CEJ of the tooth is a good parameter to follow. As this diagram shows, this is a mesioangular tooth. It's going to curve upwards and backwards. That's going to be its long axis. This way, upwards and backwards. So draw these type of diagrams looking at the X-ray on your prescription paper or any paper. Understand where will you remove the bone from. So you will remove from the distal, you will make a deep buccal gutter right till the furcation, and you will remove through and through the interdental bone between the 6 and the 7, where your elevator goes in touching the lingual cortical plate. Once your elevator has gone through this wedge between the 7 and the 8, touching the lingual cortical plate, you will start luxating on the mesial aspect, but in a backward direction. Should it be only clockwise? No. Should it be only anti-clockwise? No. Clockwise, anti-clockwise. Clockwise, anti-clockwise. Move the elevator gently, all the while nudging the tooth in a backwards distal direction into the space which you have created with your distal bone cut. Now, in a distoangular tooth, when you draw the, as you can see in this, what does it mean? Distoangular tooth is going to come out in a backward motion. That means you need to remove more bone from the distal of the crown. More bone from the distal of the crown, creating space over there for the tooth to move into that created space. Once the tooth moves into that created space, it frees itself from the constriction or from the bulk of the 7 and slips out easily out of its socket. So this is how, looking at the tooth, the long axis, the angulation of the roots, you plan the extent of the bone cut. Elevation, I don't use personally winter criers or apexos or anything. Straight elevator is the best, and elevation is everything. Invest in elevators, not in forceps. Elevation should do 80% of your job. Always have 3 elevators, a sharp narrow one which will create a wedge for you, a arrowhead one which will apply that force to take the tooth backwards, and then a broad one which will exert pressure to move the tooth. Direction of the elevation should be along the long axis, and the entire aim is to scoop the tooth out along its natural curve. So these are the 3 elevators which have to be there with you. For an upper third molar, start with the pick, then the arrowhead narrow one, and ease the tooth out in the direction in which the crown is facing. So if the tooth is facing buccally, ask the patient to close his or her mouth. Start elevating the tooth like a scoop, clockwise, anti-clockwise direction, in the buccal direction, distal direction. The tooth comes out far easier than you would have imagined, because always understand, maxillary bone is T3, D4. It expands. So what is most important in the upper third molar is getting a good ditch or a good catch between the 7 and the 8. If it's a tight contact and you're not getting a catch or a 7 is absent, then what will you do? With a straight burr, straight fissure burr, you will create a wedge mesial to the tooth, mesial to the 8. You take a flap for that, just one-sided flap, create a wedge in the bone, create a wedge between 7 and 8, use that wedge or ditch to insert your elevator and apply force in the distal and the buccal direction. Now, when you're extracting the lower third molar, it's very important to support the mandible with your opposite hand. Many times, the patients complain of pain in the opposite side and you panic thinking, what has happened? Have you subluxated the joint or have you dislocated it? Don't panic. What has happened is that the mandible gets pushed backwards on the opposite side and translated forward on the surgical side. So the patient gets pain as the condyle hits the posterior ligaments. Just wait, give some rest, ask the patient to close his mouth and then resume again. This is how you must always support the mandible when you are doing elevation or luxating the upper 8 out. Forceps will end up doing only final 20% of the job. Brute strength is just not required because you will start using the forceps only after the tooth has shown grade 2 mobility. Always use a cow horn for the uppers and the lowers because worst come to worst, if you end up even breaking the crown, the cow horn has split the roots, then separating the roots and taking them out separately is easier. I included PRF in this procedure because I feel it is extremely important for the healing of a third molar surgery. Remember, bone heals faster, but soft tissue is always an issue. So PRF is a mix of platelets, leukocytes in a fibrin network containing growth factors, which accelerates the osteoblastic migration, the fibroblastic migration to the site and enhances the speed of the healing. So once this buccal gutter done, the tooth is out, you place this APRF plug, close the sutures over it, and this is healing after 1 week. What are the advantages? There is never an incidence of dry socket. It acts as a natural clot holder, stabilizer. Flap approximation is very good. In fact, even if you don't get flap approximation, especially in the case of fully erupted teeth, either a mesioangular or a vertical, because there is PRF, there is no gaping of wound or there is no dry socket or sensitivity in the 7. End result is what we all want, a satisfied patient. Suturing, there should be 3 or 4 sutures. That's it. The distal most suture should be the first suture you take. That is on the anterior border of the ramus. Because once you suture that, the flap sits in place. Then you take the second suture, which is distal to 7. Your last suture would be the suture in the buccal sulcus. You may even omit that suture because sometimes too tight suturing over there can cause hematoma formation. When you have a tooth like this and you don't have a 7, what do? As in the third picture, top line, what you have is you create a ditch into the alveolar crest. Take out about 2 to 3 millimeters bone mesial to the 8. Once you take out 2 to 3 millimeters bone mesial to the 8, use that ditch to leverage your elevator or to fix your elevator. The elevator uses the alveolar crest as a fulcrum, and taking that use of fulcrum, raise the tooth. The distal ditch you have already made, the tooth gets raised quite easily and you can take it out of the socket. In fact, I always prefer that 7 should not be present because then my visibility is more. For a horizontal, there are 2 ways you can section the tooth. So this is a completely submerged horizontal tooth. So with this cut separating the distal root and the distal part of the crown from the mesial root and the mesial part of the crown is by a 703 straight handpiece. It's pretty easy if the patient's mouth opening is wide. In this, you go through and through till the furcation, right? Once you go through and through till the furcation, put your straight elevator inside like a VAM key. Just move it right and left. The tooth gets split. Take the distal root with the crown off by elevation. Then take the mesial root up. Or if the patient's mouth opening is less, maybe because of trismus or idiopathic, then use the disimpactor handpiece and the long shaft surgical burr and section the tooth in this way at the CEJ. Always section the tooth at the CEJ because that is the weakest part of the tooth and it's very easy to sectioning it at that area. Now, what I was talking of making a ditch in mesial to the impacted A is what's shown in picture A, that straight handpiece burr. It should go beyond the contact area, beyond the CEJ into the alveolar bone, creating a wedge or a ditch. Insert your elevator inside and push the tooth out, distally expanding the maxillary tuberosity. Many times the maxillary tuberosity fractures along with the flap. Do you panic? There's no reason to. There would be some amount of bleeding, a little bit for some time. Use bone wax to stop the bleeding. Suture the buccal flap and the palatal flap together. Before you do that, just put your little finger or index finger inside. Feel around the socket. If there are any sharp bony ledges, smoothen them with a round burr and suture it on. So don't worry if the maxillary tuberosity comes out. In fact, if you are planning to use the upper 8 for a dentinal graft, you can use the maxillary tuberosity as a source of autogenous bone and plan an implant at the same time. Now in this case, I specifically added this diagram. Do you really think there is any need to take these teeth out? Never ever take these teeth out. Taking a flap and suturing it is a humongous problem. Even after 25, 26 years, I shudder. And let me tell you, these teeth will never be the cause of anything other than if it is involved in a dentigerous cyst. If it has a dentigerous cyst attached to it, it will be the easiest thing to take this tooth out. After in the OT, of course. But if there is no cystic lesion and the tooth is in this position, let the tooth be. The tooth is not going to cause any TMD dysfunction, is not going to be the reason of any headaches, nothing. So for heaven's sake, if our upper 8 is this high up, so snugly sitting within the bone, don't disturb it, don't wake up the sleeping tiger. Now, when do you not do the case? This is a message for general dentists. When do you call a surgeon? It's not that you're quitting, but you just feel it's wiser to not experiment. So when you're starting, always start your practice with the less difficult cases. And for the more difficult cases, call in an oral surgeon. Now let's just see one video of a lower 8. Mesioangular. It was an ortho case, elective extraction, no preoperative medication, just a loading disc. So LA given. I prefer cartridges. I prefer, like I told you, xylocaine and articaine, a mix of both. So vertical incision going inferiorly downward beyond the mucogingival junction, about 1.5 centimeters from the cervical margin, along the tooth, backwards and along the anterior border of the ramus, 2 centimeters superior. Use the sharp tip of a wax spatula to separate the papilla, and always take a papilla sparing incision. The mesial would be at the distobuccal cusp of the 7th, the mesiobuccal of the 7th. The flap has to be completely a full thickness flap, clean bone on visible to you. So for that reason, run your blade twice, thrice along the same incision so that the cut is through and through. This is the P14 Euphredy elevator. Wherever you feel tenacious periosteal tags which are not getting elevated smoothly and are tearing, leave the periosteum aside, take the blade and cut off those periosteal tags. See, with a number 15 blade, I'm cutting off those distal periosteal tags. Cut them off so that they don't get in the way of surgery. One reason of profuse intraoperative bleeding is if your burr has touched the periosteum or you haven't reflected the flap very well and your burr is lacerating the periosteum as you cut. That is what causes profuse bleeding. This is the L-shaped retractor. You can see even in obese persons, this L-shaped retractor will hold the buccal flap very securely away from the surgical site, not obstructing your vision. The length of the periosteum, this L-shaped retractor should be about 5 inches in length and width should be at least 1.5 inch. Start drilling interdentally. Right, interdentally, the cut should be through and through from buccal to lingual. Saline irrigation should always be of ice cold in nature. Colder the irrigation, less the bone heating, less the bone necrosis, and faster the healing. The entire gutter should be below the furcation in the cancellous bone. From the interdental, between 6 and 7, along the buccal, distal till the lingual cortical plane. Never reflect the lingual flap. Just the buccal flap. Don't touch the lingual flap at all because the lingual flap has the terminal branches of the lingual nerve. I'm using a brushless micromotor. Can you see the depth of the buccal gutter and the width? This is the natural width when you use a 703 burr. Use the arrowhead elevator or the medium-sized straight elevator. Ask the patient to close his or her mouth. Support the mandible with your opposite hand and elevate it in a backwards, that is a distal and a upward direction. Always make sure that the conical or the concave part of the elevator touches the 8 and not the 7. So this way there is absolutely no movement of the 7. Now you can see that the tooth is stuck over there. So you have two options. You can remove a little bit more bone on the distal side, or you can section the tooth. Or what you can do, what I'm doing now is pushing the elevator on the buccal of the tooth and scooping up like a spoon. Check this out. So the deeper the groove, deeper the buccal gutter, deeper the interdental groove, that's the only way you can ensure that your elevator snugly fits into it and it can be used to pick the tooth up like a spoon. Smoothen the bony ledge with a round burr. Where do you get this burr? It's a vulcanite burr, bell-shaped or a round ENT it is called. It's indigenously made, available with any dental dealer. Flush the socket out of any debris, enamel chips, bone chips, or any fillings or cement. Flush it clean and always use clear saline so that your visibility is not restricted. You can mix it with chlorhexidine if you want, but if you use betadine, what's going to happen is that the betadine is going to obscure your visibility, right? So use clear saline. any small chips of loose bone, even if it is an interdental bone, you must remove it, as it will destroy the blood clot. It will not allow it to organize itself, mobilize itself, and you might have secondary bleeding. Pack gel foam, pack PRF, and start suturing. These are the steps. That's it. Now let's understand what is coronectomy. That is the new in thing that's happening vis-a-vis third molar surgery. Simply saying, coronectomy is a procedure when you have a deep third molar whose roots are definitely touching the nerve, where they are bending the nerve or where they are looping around the nerve, and you know paresthesia is 100% possibility. In that case, you can choose to remove only the crown of the tooth, leaving the root complex inside. So what happens is that when you are elevating the tooth, the entire tooth, when you elevate, you have a chance that the elevation may bend the nerve, may cause pressure on the nerve, may depress the nerve further, causing it to act up post-operatively, as in give hyperesthesia symptoms or paresthesia symptoms. So very simply, you allow the roots to stay where they are, only take the crown out, because crown is what is causing the problem, the pressure on the 7 or the pericoronal infection. When do you do this? You clearly do it only when the disease or the cause of discomfort of the 8 is restricted only to the crown portion. And you know the CBCT or the X-ray has clearly shown that the roots are touching the IAN bundle. These are all the scenarios where you know paresthesia is a surety, and then you decide to do coronectomy. When do you not do a coronectomy? If there is a radiolucency, if the tooth is non-vital, if it's a medically compromised patient, better to take the entire tooth out, because you don't want the roots to be a focus of infection. Obviously, if there is a dentigerous cyst attached to it, you prepare the patient, but don't leave the roots in, because the cyst may relapse. The indications for a coronectomy should be decided by the surgeon and the patient themselves. The patient should not feel that the surgeon is not removing the entire tooth because he is incapable of doing so. You must pre-warn the patient with the help of the CBCT and inform him that one of the most common complications of a third molar removal, which is very deep and close to the nerve, is paresthesia, which may or may not be come back. If it comes back, it will take almost a year, and the patient will have discomfort associated with it. Specific consent should be taken by the patient, from the patient, before the surgery, and only then should you go ahead with this procedure. What is this procedure? Same procedure as a third molar. Make the buccal gutter, distal gutter, section the tooth at the CEJ level. After you have sectioned the crown and the root at the CEJ level, take the crown out. Trim the root complex with a round vulcanite burr, so that the level of the root complex is below the level of the bony ledge or the bony rim which you have created. This enhances the bone formation over the root complex. Smoothen the bone, rinse and suture as you did for the normal third molar. What's important is making sure that there is no tooth structure above the bone level, but the tooth structure is much below the bone level, so that healthy bone forms over the tooth. These patients should be called for follow-up every 3 months, and the X-ray should be taken to check the level. Now see this is the immediate post-op X-ray. 1 year later, the tooth had supra-erupted, but the patient had no pain, so we decided to leave it there. The conclusion is that it is a simple technique that does not require any endodontic treatment of the residual roots. And yes, it can help prevent paresthesia, which is a really discomfort, source of discomfort to the patients after the surgery. So you must give this choice to the patient when the teeth are so completely submerged. So how do we sum up the procedure? X-ray reading is critical. Treat cellulitis Ludwig's first. Section according to the path of withdrawal or according to the plan of surgery which you have done after reading the X-ray. Take a wide flap. When in doubt, just remove both. Now, when things go wrong, broken tooth, avoided by elevating thoroughly, use cowhorn forceps. Intra bleeding, take a clean flap. Avoid sharp tip retractors or elevators. Secondary bleeding, flush the debris out and smoothen sharp bone edges. Dry socket, use PRF. Atraumatic surgery, irrigation with a cool irrigant. Paresthesia, if it is because of LA, so don't go beyond 6 cc LA. Atraumatic surgery, avoid lacerating the lingual flap, and if the CBCT shows the roots touching the nerve, prefer to do coronectomy. Dislocation of condyle, support the mandible whenever you're luxating or elevating the tooth. Fracture of the angle of mandible is extremely rare. That happens if the tooth is very close to the inferior border of the mandible, or you have injudiciously removed excess bone. So always take an X-ray if you feel that the tooth is really tightly wedged inside and the bone removal has been quite a bit. If you feel that the inferior border of mandible is less than half an inch or just half centimeter, make sure you put the patient on a soft liquid diet for at least 2 weeks till some sort of connective tissue formation happens, and then the fracture of angle chances are minimized. Condylar dislocation, if the patient does go into, feed the patient a sedative. Push the mandible backwards and upwards, one side at a time. Guide the mandible in position and it will be smooth. Post-operative management of bleeding, socket bleed, it is bone wax. Nothing else stops it. Don't use cautery for socket bleed or bone bleed because you will end up forming osteitis or a dry socket. Soft tissue, use a cautery or a laser, and like infiltration, inject any hemostatic. Give a pressure pack soaked with hemostatic. For edema, soft swelling, chymotrypsin. You can give corticosteroids. You can even inject corticosteroids like infiltration around the sutures, or you can give it intramuscularly. Tablet dexamethasone in a tapering dose, or an injection dexamethasone or hydrocort 100 ml intramuscular or intravenous. When is it a hematoma? When the patient comes the next day and opens his mouth and there is a serous red discharge coming distal to 7. That's when you know it is a hematoma. What do you advise the patient? Opening and closing of mouth, warm salt water gargles, and warm compress application from outside. That liquefies the collected clot. It drains the clot out and the patient's swelling comes down from the 3rd or 4th day onwards. Never ever tell the patient to apply ice on the 2nd day because frosting happens and the hematoma becomes like a hard swelling. Remove the inferior most suture the next day if the patient has come with a hematoma. Fair patients, if they apply too much of ice, they get this reddish, pinkish discoloration. Apply thrombophоб gel over there. In about 3-4 days, the discoloration goes off. Trismus is because of the medial pterygoids and the masseters going into a spasm. Treatment is by muscle relaxant exercises and muscle relaxants. It can be chlorzoxazone, tizanidine, or ibuprofen. Dry socket is only because of osteitis or bone heating or in a medically compromised patient. It's just time that will heal it. Use zinc oxide mixed with alveogel, which is a Septodont product. It's cotton mixed with iodine, betadine, and an anesthetic benzocaine, which really soothes the pain and gives an antiseptic dressing or covering to the exposed wound. Patience is a virtue in the surgery. Take your time. Stitches are extremely important. So don't give the job of the stitches to your assistant. If the patient cannot come back for suture removal, use absorbable Vicryl 40 or 30. Otherwise, black silk 40 or ethylone 30. Suturing should be equidistant bites, interrupted, and don't pull the suture to approximate the flap. The suture is only going to open up. Placing PRF inside acts as a boon. Even if there is no approximation, the wound heals magically. Now, post-COVID, please, when you're doing a third molar surgery, ask the patient to wipe their hands with this hand sanitizer. You use dermafilm to disinfect your hands. After surgery, use Surfacep to disinfect all your operating table surfaces. Use a PPE, even though you're not using aerosols. Irrigation causes spraying of the aspirate onto your face. So use a PPE, use a face shield, and lastly, keep a support group very, very handy. General practitioner, general surgeon, ENT specialist, and your colleagues should be on speed dial. So what's the summary? It's just technique, not strength. Don't take shortcuts. It's just patience, perseverance, and practice which will get you there. Just enjoy the journey. You can contact me at my Facebook, Twitter. Follow me at Wisdom Tooth Clinic. This is my number. You can WhatsApp me. This is my mail. You can WhatsApp me. I would be happy to answer your question. Lastly, I would always and most importantly like to thank my family for standing by me through thick and thin. Be it a man or a woman, it's very important to have the family support who's cheering you all the time and who's standing as your backup. I enjoy being a professional, enjoy representing my country. I want showing what India is capable of, and we are extremely efficient clinicians at touch with the best in the world. I have a message for female surgeons. You can have it all. A stands for ambition, L stands for learn, L stands for love. So all should mean this in your vocabulary, then you actually have it all. Thank you very much. And now, Jasmine, I'm ready to answer questions, whatever you may have for me.
Thank you so much, ma'am. It was a really wonderful and informative session.
That's a screenshot.
So we got some queries. First query is from Dr. Suthillo.
Yes.
He asked that does air rotor handpiece good over surgical straight handpiece?
No, air rotor handpiece should be used only for sectioning the tooth, Jasmine, and the micromotor handpiece should be used for making the buccal gutter and cutting bone. So they have two different roles.
Okay.
Never cut bone or make the buccal gutter with air rotor handpiece. You will end up causing emphysema.
All right. Okay, ma'am. So our next question is by Dr. Divya. She asked how to prevent air emphysema.
That's what. Air emphysema will be there only if you use air rotor for the entire surgery. So use a high watt suction. Make sure you have retracted the flap well and you're using a micromotor handpiece for all the bone cutting. Then air emphysema does not get formed.
Great. And Same, Dr. Divya, she asked how to prevent lingual nerve injury during sectioning of teeth and suturing.
Yeah, during suturing, make sure that you don't compress the lingual flap. Take light sutures as superior to the lingual margin as possible. And while sectioning, you're not sectioning the lingual cortical plane. Restrict your burr movements to the tooth and never separate the lingual flap.
Okay, well explained. Next question is by Dr. Uda Kher. He asked also any risk of sectioning the tooth air and air turbine after raising the flap.
No,
He asked
you,
even with the high wax suction.
no, there is no risk.
Okay. Then next question is by Dr. Suraj Jillo. He asked if the roots of impactive molar are just near to inferior alveolar nerve, can we leave 1/3 of the root piece there without any future?
That is what's called as a coronectomy procedure. So leave 1/3 or 1/4 of the root pieces behind intentionally so that you don't pressurize the nerve or damage the nerve.
All right. All right. And next question is by Dr. Tejas. He asked, if in case the roots remain after extraction and not accessible for removal, how many days does it need to migrate coronally?
It will take almost a year, year and a half. You suture it. Don't suture it with sharp edges. If the roots have got broken, leave them there. Use a round burr to smoothen the bony margins, the root surface. Push your finger in the socket. Make sure that there is smoothness. There is no hard ledge or anything. And once you have done that, pack it with PRF. If you don't have PRF, plain gel foam, suture it. The bone formation will happen over the roots, right? And it will take about a year, year and a half for the roots to migrate coronally. They may not even migrate coronally. They might stay the way they are. Leave them.
Okay.
If the patient complains of pain even after 2 to 3 weeks and the wound has not healed, then you have to retake the flap and remove the roots.
So next question is asked by Dr. Suraj Hillo. He asked, why doesn't lingual bone plate shaving is recommended?
No, because lingual plate should not be touched because that's where the terminal fibers of the lingual nerve travel over there, right? They are present, the terminal nerve. So if you compress the lingual cortical plate or if you compress the flap, then you're definitely going to have paresthesia on that side of the tongue.
All right. Next question is asked by Dr. Divya. She asked any comments about INR ratio. Do we need to consider or straight away stop warfarin?
INR ratio is not for every case. Only if a patient has had infection in the past or has a G6PD deficiency or has a thalassemia disorder or something, then you take care of the INR ratio, or if he's a heart patient or something like that. Not for a normal healthy patient.
All right. And she also asked, and any ideal instrument for root stump removal for maxillary third molar?
Luxators or the thinnest straight elevator what you can find. You can even use the sharp tip of a wax spatula to take the root piece up. The key is to create a ditch around the root piece where your elevator can engage itself, hook around the root piece and pull it out.
Okay. Thank you so much, ma'am. I hope these tricks will really be helpful for every one of us.
Thank you, Jasmine, for being there today. And thank you, Dr. Kianor. And thank you, Rakesh, for the last minute reshuffling and making sure it happened.
Thank you so much, ma'am, for taking out time to speak to us on very important topic of this wisdom about wisdom teeth and telling us tips and tricks for easy clinical practice. Thank you so much. And it was really a great session.
Thank you.
And hosting your session was really great.
Thank you. Stay safe, stay at home, stay healthy.
Thank you, ma'am. So we'll be back with our next session in few minutes. For more information regarding certificate, speaker schedule, etc., you need to visit www.gomha.org. Till then, stay tuned. Thank you.